All right, welcome everyone. This is our 13th VT Reach session. VT Reach stands for Virtual Teleconference, Reach, Explore, and Aspire to Careers in Healthcare. And we are so excited to have two fantastic providers here tonight.
So joining us tonight is Matt Kinsey and Sarah Wagner, and we are spotlighting pulmonary and critical care medicine. We're really excited. These two providers work together in a lot of their care. And so without further ado, we will start off with Dr. Kinsey and his inspiration into medicine.
Yeah, so I got interested in medicine. One, I just really liked science, and I had experience with medicine because I had cancer when I was a kid. I was about 8 years old, and had gone to college at University of Idaho, and really was studying chemistry and molecular biology and more of the sciences then, but then took a graduate level biochemistry course, which was all sort of more detailed health systems, if you will, and got kind of hooked. And so took off from there. You want me to keep going? Okay, sorry. And then went to the Albert Einstein College of Medicine in New York, did 4 years there, and then did internal medicine residency at Beth Israel Deaconess, and a pulmonary and critical care fellowship which was in the Harvard combined program. So it was at Massachusetts General Hospital and Beth Israel Deaconess in the Brigham. And then I went on and did an interventional pulmonary fellowship, which means I largely do minimally invasive procedures for people that have lung problems, you know, a tumor in the airway, or aspirated a steak, you know, typically at a wedding. Weddings are high risk time for steak aspiration. And then got a master's degree in public health with a focus in clinical trial design and biostatistics at the Harvard School of Public Health, and then came up to Vermont, where I practice with Sarah in interventional pulmonary, and I do research with the rest of my time. And so Sarah and I typically see patients that have, most commonly, a tumor in their lungs, something that looks like a tumor. So that can typically be smokers, but you know, lung cancer in never smokers is more common than pancreatic cancer. It's probably not realized. We actually have a much higher rate of lung cancer in never smokers than would be expected compared to the rest of the nation. And so we see a lot of patients that have lung cancer or have some other sort of an airway problem, and then we perform minimally invasive diagnosis and treatment to try to see if we can help that person out. Yeah, and this is sort of work-life balance. I don't know. I always I like how you say integration. Actually, that's a better word than work-life balance, I think, because work-life balance sort of always feels a little bit like a tug of war to me. I guess this is a little bit of an aside. I guess I would say I always think about it as what is the best way you could be contributing at any given time. That may be your family, that may be to your patients or to society. And so, you know, work is one of the ways you can contribute. So I think that sort of takes some of that away, but typically that's what my week looks like, where I have clinic on Mondays, Tuesdays in the OR, and then Wednesday, Thursday, Friday, I do urgent cases and research. And then I hadn't been doing much time in the ICU covering the intensive care unit, but during the Omicron spike, I sort of got pulled back in under duress. So, and that happens. So that's sort of how it goes.
Thank you, Dr. And if anyone has questions, they can put them in the chat now. We'll address all questions during the next Q&A.
And next we'll hear from Sarah Wagner and her inspiration into medicine.
Hi guys, thank you so much for having me. My inspiration for going into medicine started really early. My mom was an ER nurse. She's now a nurse practitioner as well. When I was growing up, she was an ER nurse. And so she would work evenings and she would come home and say goodnight to me before she went to bed. And I would always ask her if she took care of any kids, because I always wanted to know like what kind of accidents were happening. So that's when I really got interested in being in medicine. So I graduated from high school and wanted to go into nursing school. I spent a single year at Simmons College in Boston and then wasn't quite sure that that was really what I wanted to do. I kind of realized how much money I was spending on college and was feeling a little uneasy about things. So I decided to come back to Vermont and take some time to collect myself a little bit. And so I took a couple of years at community college doing some undergrad prerequisite work, and then ended up finishing my bachelor's degree in nursing at Norwich later on. And then I got a job in the intensive care unit, and probably about 4 years into that, decided to go back and get my master's degree and become a nurse practitioner. So when I had come back from Simmons College, I knew that I had to get a job and somehow support myself. So I started working as a unit secretary on what was the hematology oncology floor at the time. And then after working as unit secretary, I got my license to be a nurse's assistant. And we did a lot of end of life care there. So that really started my passion for oncology patients. And then after graduating as a nurse, I started working in the medical intensive care unit. And that's when I met Matt. He would have an occasional patient that would come to the ICU, and I had taken care of a couple of them. And then I knew that he was looking for an advanced practice provider to join his team. So I had approached him with interest when I was looking to graduate from school, and interviewed with him then. And then I started with him after having my first baby in 2015. So my job responsibilities are really varied, and I love that about my job. I primarily work with Matt with interventional pulmonary. I used to do sort of split time between interventional pulmonary and general pulmonary care, a lot of COPD and asthma, but now I've really tried to limit my schedule to being mostly interventional pulmonary patients. We have a variety of patients that come to see us for many different reasons. And so it's great to try and figure out what's going on with them. And it's primarily my job to do a lot of preoperative evaluations on patients to try and see if they're safe, essentially, to undergo a procedure with us in the operating room, making sure that they can tolerate having general anesthesia, that sort of thing. I also see a big part of my job responsibility is forming a relationship with our patients. I generally am the person that they see the most out of our team, and I like for them to feel like I am their point person and they can rely on me to be trustworthy. So that's my job sort of in clinic. And then on Tuesdays, we're in the operating room all day. It's a great change from being in clinic every day. We get to work with an entirely different group of staff, which is really fun and rewarding. Integration, I agree, is a good way to put it. So I work 4 days a week, primarily, usually about 8 to 5, and Tuesdays I'm in the OR. Thursdays I'm at home taking care of my 3 little kids. I thankfully do not have to take call, so I'm off as soon as I leave the hospital, which is really nice, unlike Dr. Kinsey, who's on call all the time.
Okay, well, thank you very much, both of you, for that great background and what the two of you do. And this will be our first Q&A session. So if you have any questions, please feel free to put them in the chat. I'll start with just a question that for both of you, just kind of an easy one to start us off. But what would you say is your favorite part about both of your jobs?
Sarah, you want to go first?
Sure. I think, like I said earlier, I think forming that relationship with my patients is the best part. I think I really enjoy being their person to have that connection with and to build that trust with them, because generally we're meeting patients at, one of the worst times of their lives. They're facing a diagnosis of lung cancer, which is frightening for them and their families. And so it's nice to be that person.
Yeah, and I agree. I think the relationship with our patients and their families is, I think, the best part of our job. I think it'd be the most challenging. I think the example of that is exactly how Sarah and I ended up working together, right? When we were interviewing, our team was interviewing for another provider, for an advanced practice provider. We actually hired Sarah straight out of as a MICU nurse when we had people that actually had applied that had more experience, but it really was Sarah's, I'd worked with Sarah. I knew she was really smart, knew she was really dedicated, and I knew she really was committed to her patients and knew how to help people through that process. And so that's been, I think, one of the things that, and Sarah and I have kind of continued that as we've built our team. I think that's one of the things, just as an aside, that Sarah maybe didn't tell you about her job but it's really a program that she and I have built together. And so Sarah's been, instrumental in deciding who the nurses are that we include in our team, right? And how we design the procedural workflows, and when we see patients and when we see patients back, and all the things that go into that. And so I think that's an interesting, I think it's interesting to do. And I think as Sarah's, done as much of that, and more so even than I have. So I think it's another nice aspect. And we design a lot of that around how to improve that patient experience.
Thank you both. I have a question from the chat asking, are you seeing an increase in pulmonary diseases associated with the increase in people vaping?
Yeah, it's a good question. So yeah, there's a lot of, and you guys have probably seen this, there's a lot of data around acute vaping related in lung injury, basically meaning you have a reaction and, early on typically in the vaping use, but it can be later, but it's not really necessarily a cumulative effect, but it can be severe. People die from it. You really shouldn't inhale anything. But we don't know the long-term consequences of vaping. Probably it's going to be, there are going to be a number of long-term consequences. Any inhaled organics are bad for your lungs, right? We know that from people who survived the World Trade Center dust in New York, right? And have higher rates of sarcoidosis, and their lung function is worse, and they have more cancers. And we know that if you grew up in a resource poor setting and cook indoors and you inhale smoke, any inhaled organic matter tends to have almost universally, so I'd even walk back tens, but universally has detrimental effects on your lung function and typically carries a risk for lung cancer.
Personally, no, because that's not the type of patient that I see. That generally goes to other providers within our practice.
Okay, thank you. Another question from the chat, which is probably one that, a lot of people are wondering, just how COVID has impacted your jobs, obviously being a respiratory illness and a virus that primarily affects the respiratory system.
Well, one of the main things that we felt with COVID, I do not work in the ICU anymore at all. I primarily work outpatient and in the operating room. One thing that really was changed in our practice was the ability to schedule patients in the operating room with COVID. As soon as they made the change to test everybody that was coming into the operating room, it really limited our ability to get patients on the schedule and has delayed their care because of that. We used to see patients in clinic and at times perform their procedure the following day, and having to get them COVID tested, and then having them quarantine at one point really, just pushed back their care. So that was really challenging. We also take care of a very vulnerable population. We take care of patients that have chronic lung disease, that are either, getting diagnosed with cancer or have cancer and are having treatment for that cancer. And so their fear around having COVID or actually contracting COVID and becoming sick has been challenging.
I'd agree with all that. The only thing I'd add is that we also see, I think, people who, for instance, if you had a lung cancer, it's much worse at this point because there were so many delays in care. People were either afraid to come in, told not to come in, quarantined, whatever it is, missed screening tests, all those kind of things. So.
Thank you for sharing that. And I have a question. I know you talked about your roles as interventional pulmonology, but could you talk about different other sections of pulmonology that someone could go into? What are other avenues of this job?
Yeah, so I think one of the nice things about going into pulmonary medicine is that, there are a lot of different things you can end up doing. So you can see pulmonary patients in the outpatient setting, and I'm board certified to do that. Sarah does that and was the primary provider for a number of COPD patients, those kind of things. You can work in the intensive care unit, which is obviously very different. We see inpatients, patients who are admitted to the hospital, but not in the intensive care unit with lung problems. You can go into interventional pulmonary medicine. You can go into sleep medicine. Those are additional fellowships beyond pulmonary and critical care. You can, so I think there's a lot of settings, there's a lot of different things you can do. You can do research, you can do, so it's a nice jumping off point. There are a lot of things you can specialize on. There's colleagues of ours that focus just on studying how the lungs work and lung mechanics. There's people that study, really high altitude sickness, right? We used to run studies in high altitude sickness, which has always typically been a pulmonary and critical care problem. So there's a lot of different things that you can do from pulmonary medicine.
There are 3 advanced practice providers in the pulmonary clinic right now. I'm one of them. The other 2, one of them works in interstitial lung disease. So that's more along the lines of, kind of widespread lung dysfunction type problems. And the other one works primarily with cystic fibrosis patients. And they have an entire team surrounding the cystic fibrosis program.
Yeah, and it's a good point. Those aren't even separate fellowships. That's just people that have kind of taken on a niche program within pulmonary medicine. So that's a great point, Sarah. Yeah.
Wow. Okay. Thank you. And then another question from the chat that someone was wondering is that if you both kind of had the option to go back and redo your education, do you think you'd still end up in healthcare knowing everything that you know now?
Yeah, I think I would. We were just having this conversation in clinic last week of like, what would you do if you didn't work in healthcare? And, like be a barista or work in a greenhouse came up. But I think that, yeah, ultimately, I think that I would end up in healthcare.
Yeah, I mean, I definitely would. It's a challenging time to be in healthcare, but it's a challenging time to be doing anything. And if you can do something valuable and make a contribution, then that's worthwhile. So no, I would do the same thing.
Thank you both.
That's encouraging.
Yeah. I had a question for you, Dr. Kinsey, about your time as a research assistant, and if you could talk a little bit more about that and where that really led you in your career later on.
Yeah, so I was a little bit, Jillian, a little bit like the path that you and Lily were on, and that I had to take my MCATs and that kind of stuff when I finished my undergraduate degree, and so I worked at the Fred Hutchinson Cancer Research Center in Seattle, Washington, as a research assistant. And I think the thing that probably was the best about that is that there was a program called research experience for undergraduates. It was a National Science Foundation program. I think it still exists. And you can write a grant. And what's nice about that is that essentially will pay your salary as a research assistant to go work in a lab and get you some additional experience in that kind of setting. And so I worked with a number of physicians who were doing research in that setting. And yeah, I think I learned a ton. It was great.
And you mentioned this also for Dr. Kinsey, you mentioned that you still kind of do some research currently. And I was wondering if you could kind of share what research that you work on and what it mainly focuses on.
Yeah, sure. So I've always kind of been in research in some form or another. I just enjoy that process. And one of the things that Sarah and I really see is that, we'll diagnose a cancer, but then, so we'll go in, perform biopsies in the lung, and then the patient has to go on and get a number of other tests to figure out how far the cancer might spread, all these kind of things. And they may not get treated for a cancer for another month. And that would be pretty standard, and it can be, and there's good studies to show it can be even 8, 9, 10 weeks out from there. So, one of the things that Sarah and I work on is trying to begin treating the cancer right at the time we diagnose it. So at the time we're really getting a biopsy of the cancers, can we deliver a drug to start treating the cancer right then? And it has the obvious appeal that potentially you could get much higher concentrations of a drug to treat the cancer into the lesion itself without having to give it through a vein and expose the drug to every tissue in the body. So that's the main focus of what we do. So we run clinical trials, and then we have a research lab as well, where we work with engineers and immunologists and pathologists around trying to make that process better. How do we deliver that drug in the right way? How do we dose it correctly? Those kind of things.
Thank
We
you.
also have a study where we take an extra sample out of the patient once we've confirmed that they have a diagnosis of cancer. And then one of the researchers over at UVM tries to grow cancer outside of the body. That's one of our studies as well, because it turns out it's really hard to grow lung cancer cells outside the body.
Right, it makes my head hurt. Right, we can't just stop growing inside the body, but as soon as you try to grow it on a plate, it dies.
Interesting.
Frustrating.
Yeah. I have a question for you, Sarah. Can you talk about your favorite part of what is the nurse practitioner training and just what you would want to share with a student potentially interested in that route?
Yeah. I went to UVM's program for nurse practitioner school, and UVM's program is geared towards being a primary care NP. So my training was mostly kind of internal medicine training and planning to be the primary care provider for somebody. What's really nice about being a nurse practitioner, though, is that you can take your license and then practice in a variety of settings. You're also not tied to what you choose. So I work with Matt in this very small niche of pulmonary medicine, but I could go and change my job completely and do something very different, like go and do GYN care, or go work for a company providing occupational health for someone, like workplace screenings, or do, I don't know, like veterans assessments, those sorts of things. So that's really cool with the nurse practitioner degree, is that, you're not really tied to the specific thing that you're trained for necessarily. You have an overarching degree that allows you to be flexible.
Okay, great. And then I have a question for the two of you. So, just mentioning about how the types of patients that you primarily deal with being, ones who are getting a lung cancer diagnosis. What are some things that the two of you do to kind of manage your mental health, especially with really difficult cases and tough patients as well.
We talk to each other. I think especially after really tough cases, we will debrief with each other. I think Matt and I are both very appreciative of having each other because we know not a lot of people really know exactly what we do. And so it's hard when, there's not like you can go back to an entire staff of people and really talk about it. So we debrief with each other, but we also have super supportive support people around us, including the nurses. And I know that our clinic nurse, Brittany, is very supportive, and we can have some really tough family of patients that can be really challenging. And Brittany is great about running interference, honestly, a little bit, and just providing that extra layer of buffer sometimes that you need to just take a break from being the contact person for that patient's family. And then we both exercise. I think that really helps too, to just burn off some energy and angst.
Yeah, it's funny. It's a challenging question, and I think Sarah's absolutely right. And I think having somebody you trust, not just to, I mean, debrief, I think gets thrown around, but you really got to have somebody that you can ask, hey, did I foul that up? And that can be everything from a technical choice. Oh, did I, use the wrong scope or the wrong needle or whatever? Or, should I have not brought that up right then? Did I not, was I looking at the computer too much and not looking at the patient? So that's one, I think, having somebody that'll stab you in the front, right? When you need it and say, hey, we could have done that better. That's helpful, right? Because you have to, I think you have to unhinge to some degree the outcome of what happens to a patient from, what you and your team did. Because we can't honestly always, a lot of our patients are going to die, and that's how it is. I mean, not typically, during the procedure or anything like that, but in a short time, and that's hard on your team. It takes a toll on your team, those kind of things. So you have to have that. And then I think the exercise piece, so I agree with Sarah, but it's a little bit of an extension of, you have to figure out some way, and it was a pediatric oncologist that told me this, you have to figure out some way to not carry that in the front door always with you, right? If it doesn't, and that's not always an easy thing to do, but I think, again, realizing that you want to contribute to your family too, you want to be helpful to your kids, your wife, you want to be the kind of person they can depend on, then you have to be available to them too. So I think a lot of it is managing your own mind, honestly, and realizing like what is the best thing I need to be doing right now, and I need to focus on that.
Thank you for sharing that. I believe that's such a hard aspect of healthcare right now, and hearing both of your advice for that is really, really important. So thank you. I want to ask you, Dr. Kinsey, about what an internal medicine rotation or what an internal medicine residency looks like, since it's more of a broader residency compared to other options.
Yeah. Internal medicine is, I think it's a great choice. You can do a lot of things from internal medicine. The residency itself, you basically you progress through stages of responsibility over typically a 3-year period, and you progress through different subspecialty disciplines in medicine, right? And that may be taking care of general medicine patients admitted to the floor, meaning that could be COPD patients or patients who've had heart attacks or any of the classic things that you might think of, right? Non-surgical appendicitis, anything like that. And working in the intensive care unit, so you get exposure to that as well. And then you'll also work on various subspecialties, right? So you might work on a bone marrow transplant floor. You might work on depending a little bit on what the hospital does where you train. You could work with like what Carlos Mariquin does, Bridget's husband, where he's a transplant surgeon. So You could be on the transplant medicine side of that, meaning you're taking care of patients who've been recently transplanted or preparing for transplant. So it can have a really broad exposure to a lot of different areas of medicine, and I think gives you a nice basis for understanding all things disease, if you will. So yeah.
All right, I'm going to ask just one last question before we move on to the case study. But kind of speaking about, all these different types of, avenues that you can then take. For the two of you, when dealing with patients who are coming in and, getting this potential lung cancer diagnosis, is transplantation something that you often see, or is that like a viable option for these patients, or is it usually not something that can really occur? I was just kind of wondering what the kind of rates of it, or if that even really happens. I'm just not quite sure.
Yeah, it's a great question. The answer is typically no. To undergo a lung transplant, you need to be, it varies a little bit, but typically 5 years out from any cancer diagnosis, because of the risk of recurrence. And the problem when you have a lung transplant is your body, when your body's used to seeing all of the tissues in your body. And when you put something from another person in you, your immune system gets a little confused, and it thinks that might be a bacteria or a virus or something else. And so you have to be on these medications to kind of knock your immune system down. And when you knock down the immune system, you're also a little bit more likely to get a cancer. So it's a trade-off. And so very few of our patients that have had a lung cancer go on to get a lung transplant.
Thank you for clarifying. And so we're now going to move on to the case study, but for our viewers, if anyone has a question that comes up during this, you can again put it in the chat and we'll address it afterwards.
Yeah, so this is a case that Sarah and I took care of, and it's kind of highlights, I think, as much the case. I just wanted to include it because you kind of see a number of different people who are involved in this case. So this was a very lovely gentleman who was a smoker. And if you don't know this, it's worth mentioning. We screen for lung cancer with CT scans, with a CAT scan every year in patients who are current or former smokers. So he unfortunately was not getting lung cancer screening, got a pneumonia, got an infection in his lungs, and he was found to have this nodule in the lung. So that arrow is pointing to the airway, and this kind of thing over on the right side of the screen. I don't know if you can see, you probably can't see my mouse, but there's that kind of rounded lesion in the lung there on the right side. Yep. Go over there. Yeah, that thing, right? So that's the lung cancer. So, we just knew it was a lesion. Sarah saw this gentleman, and she, this is kind of typically how he works. She saw him, talked to him, made sure he understood this could be a cancer. You're going to need a biopsy. Here's what the biopsy is going to look like. And then, typically that also includes a conversation of what the process is going to look like if this is a cancer, just to sort of prepare people mentally for what's coming. And then he was also interested in participating in a research study that we have where we deliver, as I mentioned, a drug directly into the tumor to start treating it right at the time of biopsy. So you can flip to the next slide. This is the operating room. The big sort of thing on the right-hand side of the screen is a CAT scan. Basically, it's a CAT scanner that we use in the operating room. And then there's a robot that's connected to the patient's breathing tube, and we drive the robot into the lung and out to where that lesion was you saw in that picture on that CAT scan, and we take biopsies of that. And then in his case, we also, as part of the research study, delivered the anti-cancer drug directly into the tumor. So we took biopsies. The pathologist came into the room with us. They said, this is a cancer. And then we delivered the drug directly into the tumor itself. And then you can flip to the next slide. And this is kind of what this is the robot view. I like to include this one just because I think it's a cool view. but that's literally the robot lining up under an electromagnetic field, and that's that yellow lesion is that cancer. And so we're preparing to take the biopsy from that location. And then you probably flip down to the next one, if you don't mind. Yeah. And this is our team. And this I included just to highlight, sort of as Sarah was saying, all the different sort of roles that are involved in the healthcare team. And so from the left, right, that's Jenna, who's an OR nurse, and then Jocelyn and Laura, who are respiratory therapists. And it's funny, I was just talking to my wife, who's a nurse, and I don't think either one of us knew that respiratory therapist was really a career when we were, coming out of college. That just wasn't really necessarily, but another great career, probably a conversation for another time, but they also do a number of really interesting things. And then there's Sarah, that's Brittany, our nurse, standing next to her. I'm kind of standing behind them. And then that's Scott McWilkin, who's an anesthesiologist in the far back, either giving rabbit ears or the peace sign, we're not sure. And, but they're also anesthesia assistants, and there's not one in this picture because there wasn't one that day, but it basically works as an anesthesia provider in many of our cases. And that can either be an anesthesia assistant as a separate degree or as a CRNA, becoming a nurse first and then becoming a nurse anesthetist. And then Emily Ducombe, who's one of our fellows, so she's a pulmonary fellow, and then Sam, who's another one of the OR nurses. And so I think it highlights the number of people and different ways you can be involved in healthcare, at least in the operating room setting on this slide. And then I included one other slide, which is just an outline of our, if you don't mind flipping, yeah, this is just an outline of our kind of our research infrastructure, but I highlighted it mostly to include examples of other ways to be involved in healthcare on the research side. So we have research coordinators, we have research nurses, we have, when we do deep learning and quantitative image analytics, we work with engineers and physicists, we work with immunologists, that's what Ralph Budd is, and they do the flow cytometric analysis. We work with pathologists, computational modelers, people with further clinical trials expertise. There's pathologists on that side, surgeons. So there's a number of ways that you can be involved in healthcare, even in sort of the research infrastructure as well. So that's the only reason I included that slide, just to kind of highlight those pieces as options, I think, when you're thinking about careers.
Thank you. I had a question when you were showing the biopsy with the robot view. I wanted to know, when you were studying and came into medicine, was this the standard, and where do you think this is going?
Oh yeah, no, this was definitely not the standard. And honestly, this has only been around for about 3 or 4 years, really. So this is where it's going. And it's funny you asked that, because I spent, I don't know, thousands and thousands of hours doing bronchoscopies with what's more like a traditional scope, like what you would expect to see. And this is an Xbox controller. Legitimately, they licensed the technology from Microsoft. So this is an Xbox controller. So I had my brother ship me an old Xbox that he had, and I had to train in the basement with the kids, like figuring out how to, because I wasn't an Xbox guy. So this is where it's going, absolutely. And it's just going to continue to get more advanced. The robot that the thoracic surgeon uses actually has, you insert 2 small, so this runs off a single camera. It's not a great view, it's on the left side, but has 2 small cameras. And then the image is reconstructed in 3 dimensions. So even though she sits in what looks like a phone booth on the side of the OR, and the cameras are in the patient, she's a solid 15, 20 feet away from the patient, operating virtually. So that's definitely where the world is going. And it's certainly an exciting field, and one which, there's a lot to be done. There's a lot of advances to be made.
Wow. So prior to this newer procedure, were to do a biopsy, was it a much more invasive protocol? Like, or was it still classified as minimally invasive?
Yeah, it's a great question. So we still did minimally invasive biopsies. We couldn't get out as far. So a lesion, for instance, where this would have been, we would have said, well, we can't get to that one. You now have to have two procedures. You'd have to have a procedure where we go in and biopsy the lymph nodes with the scope. And then you'd have to have a procedure where you put a needle from the outside in under down in interventional radiology, and they stick a needle into the lesion itself. So what this does is this allows us to basically perform two procedures for the patient in one setting. So that's been the real jump for us, is the area we can get much farther out in the lung. The airways just get really small. And so that's why the robot's needed.
And then I have a question from the chat just going along with this, is that do you find this more advanced technology more efficient as well?
Well, it's efficient for the patient, meaning that, the patient now only has to have one procedure instead of two, and that cuts weeks off of their time to treatment, the time from when, somebody says, hey, this looks like it could be a cancer, to the time you get it sorted out and start treatment. So it's much more efficient for the patient. For us, it takes longer. The minimally invasive, the higher tech it is, typically the longer it takes. But this is, again, one of those things that's interesting kind of roles in medicine, right? Is that, it turns out Sarah was really good at helping to kind of develop these workflows and working in the OR. And so we lean on her a lot for these kinds of things. And that's probably a function of her background, training in the MICU, all those kind of things. So, it's interesting. People can apply skills within these new technologies that you wouldn't have necessarily. I mean, it'd be great if she would have been a gamer, right? If she would have worked at GameStop, like that would have been perfect. But, we do is what we can do, right? So.
And I have a question for Sarah. If you could just kind of maybe describe in more detail, what your exact role in the OR is, being an NP working in the operating room.
Yeah. It's interesting, when I had first approached Matt about joining the IP team, he actually had to check and see, are NPs licensed to be in the OR? What's that role look like? Because there are not many NPs in the operating room. The majority of advanced practice providers that work in the operating room are PAs. So for my role in the operating room, a lot of times Matt hasn't met the patient before we bring them to the operating room. So I usually go out and meet the patient in pre-op, bring Matt with me so that they can form a relationship together as well. I kind of run through the patient a little bit with the nurses in the operating room so that they kind of have an idea of the background on the patient. I mean, they can read our notes, but it's not quite the same as when you get a rundown from somebody. Matt and I both talk to anesthesia about concerns that we have over the patient, how risky are they, things that we could try to do to try and mitigate that risk. And then I act as a first assist. So Matt and I commonly are both performing bronchoscopy on the patient, kind of back and forth. Matt primarily drives the robot when we do that, but we take biopsies in patients' airways, and both of us do that. We both discuss things with pathology when they're in the room with us, because they also come in the room at the time that we're doing the procedure and look at slides that we're making to try and help guide our work. So I usually tell them about the patient and talk to them about what they're seeing, try and help Matt decipher whether we think that we're biopsying the right area or if we need to move around a little bit to try and help get better tissue. And then once the procedure is complete, we check on the patient in the recovery area. We update the recovery nurses about what we should be expecting. We try and provide the patient with some anticipatory guidance of what to expect once going home, so that if something does happen, they know what's expected and what's an emergency and they need to come back to the hospital for medical treatment. Just to try and kind of smooth that transition of you just got through this big procedure and I know that you're really nervous, we've got you, and this is what you should be thinking about. And then when we leave them in the recovery area, they know that they have follow up with us in a couple of days to review their results.
Thank you. And this is just a quick question bouncing off of that. You both talked about how the technology can make the operating room longer. How long does a procedure typically take you? Just how many hours on your feet, that kind of thing.
Yeah, so the average is probably around an hour and a half, maybe 2, somewhere between then, depending exactly what we're doing. We've done, Sarah and I have done cases where we've grafted airways, where we've, basically there's been a hole in the trachea and we've placed a graft and some of those kind of things. And those are some of the longest cases we did. That's probably a 4-hour case, I think, was what that one took. Mm-hmm. So that's kind of the range.
And we generally try to do between 3 to 5 a day.
Yeah.
Okay, thank you. And then a student has a question in the chat about what are kind of the signs or like context you use to ensure that you're biopsying the correct place or the correct part of the lung. I know you mentioned, you use the CT scan, but are there any others that you use that are kind of more specific, or yeah, I guess would be the question.
Yeah. Well, I mean, we drag pathology into the room with us. So, they put it under the microscope, and the binoculars of truth then weigh in on whether we have reached the lesion or not. And, it can be tricky because sometimes we'll biopsy. It's actually a really good question. Sometimes you can see that you're biopsying the lesion under CT scan, but sometimes there's parts of it that are fibrotic. Some of it are just inflammatory, so it's not all the same. They're actually really heterogeneous lesions. And so, you may take some biopsies from what's clearly in the lesion. You can see it on the CAT scan, you can see it on the robot, but you may not get a diagnosis, and then you got to move. That's where Sarah was talking about, we adjust, those kind of things. And when I don't know what to do in the OR, I'm not sure, or sometimes I just ask Sarah, right? Like she weighs in, so she's instrumental in helping make that decision of what do you think we should do next? Should we do this? Do we get everything we need? So it's nice to have a colleague that you can trust, in that kind of setting.
Thank you.
So we use CT scan, but we also use ultrasound.
Yeah.
Not for peripheral lesions, but looking at the lymph nodes, we use ultrasound, which gives you, real live feedback of whether or not you're in a structure or not.
Thank you. And another question from the chat. What is the most interesting case you've had? Or again, just elaborating on that, a case you haven't forgotten or really sticks out in your mind?
Well, you want to go first, Sarah?
You go first.
Gosh, I mean, there's a lot of, I always joke that we have the most interesting, and it's not really a joke to me, but I honestly think we have the most interesting practice in the hospital. So we see a lot of interesting cases. We talk about lung cancer because that's the thing we see the most, but whenever there's something unusual going on in the lung, we typically hear about it. So we see a lot of other systemic diseases that are manifested in the lung. Yeah, I mean, the airway we grafted was a really interesting case. Guy who had a surgery for lung cancer about 10 years earlier, actually didn't have lung cancer, but the surgery had left him with a hole in his airway. Really nice guy, just, nothing but great things to say about it. Used to be a doorway gunner in Vietnam, and just the nicest guy you'd ever meet. And and so we spent a long time with him trying to fix that, and temporarily fix it. Then he had some other airway problems. Eventually the graft kind of came apart, and eventually he died of kind of some other causes, actually. But yeah, I mean, that was an interesting case, probably more memorable. As interesting as the case was, probably the patient's even more memorable, to be honest with you.
I would say a lot of the things that we do are pretty similar. You know, we see patients that have new diagnosis of lung cancer and we get them through the process as quickly as possible. There are some things that are, you know, unanticipated, like going in and thinking that they had an obstructing lesion in their airway, and you come to find out they like inhaled peas at some point and they just have peas stuck in their airway, and we take those out and they're fine. You know, that's like a little bit, you know, it's nice. It's a nice change from not having cancer. But I would agree with Matt. I think the people that stick in my mind the most are the ones that we end up developing a relationship with and taking them back to the OR repeated times, having to help them through complications of their cancer treatment, you know, fibrosis in their lungs when they actually no longer have lung cancer, but now they're having problems from the treatment that they got for their lung cancer. Those I think are the patients that I remember the most. There's also been a couple of patients that, you know, generally these procedures are not bloody, you know, very minimal blood loss. We're not really doing a lot of cutting or any of that business. But there have been a couple of procedures that we've had lesions that have just been really bleedy, and that's always anxiety provoking.
Wow. And kind of just like speaking about kind of the longer term of the treatment of patients, for the two of you who are, you know, dealing with the interventional side of it, and once you know, biopsy these lesions and find out that it is lung cancer or whatever, do you then like pass along this patient to other providers where their care kind of gets continued with someone else, or are you, the two of you, do you get to kind of see the patient throughout the rest of their care?
We have a little bit of both. A little bit of both. Yeah. So, you know, the patients that, you know, just have a lesion that needs a biopsy and kind of move on. That's definitely, we have a number of those patients. To be honest with you, if that was the only patients we saw, I probably wouldn't do it. I'd probably do something different. But, you know, we'll have a number of patients that'll show up and will have a tumor in the airway that we have to laser out or place a stent. And then that patient is kind of ours for a long time. So then we're part of their treatment team, meaning we'll have to go back in, or we'll have to deliver cisplatin in to treat the tumor, to open the airway up. So there's a number of patients that we have that we spend, you know, a lot of time with and watch really closely. You know, and those patients we're really tied to, partially because, you know, there's no other team that handles patients with an airway stent, you know, until you get to Boston. And so, you know, if you have an airway stent, you live 4 hours away in New York, you know, guess what? We talk, right? We want to know what's going on with you. And so, yeah, so we have a number of those patients too that we see and have kind of longer term relationships with.
There are times as well that we are part of their diagnostic part of their care. They kind of go and get treated and then have recurrence and then come back to us. So there are some relationships too that we take kind of breaks from each other for a bit, and then they come back to the interventional pulmonary team later on.
Thank you. And I have another question for the both of you. You both have such incredible roles, and I wanted to know, is this always what you pictured yourself doing, or were there moments in your journey that really allowed you to pivot and kind of change and take a different path that have led you here now? Within medicine specifically too.
I didn't know that interventional pulmonary was a thing until I met Matt. He was the first interventional pulmonologist at UVM. And to my recollection, I can't remember working in the MICU, needing to send somebody to Boston to have some sort of procedure in their airway. I think honestly, a lot of the practice at UVM was that if you came in with a lesion like that, I think a lot of times they tried radiation to see if that would shrink, or they would kind of reads in the line of like, I think this may be the beginning of the end of your life. So I think Matt coming to Vermont and joining, starting his practice at UVM has really changed the care of the people that are in our area. And it's the only job I've ever had as a nurse practitioner, and I love it. So I can't really see anything else.
Yeah, I don't know. That's a big question. There's a lot of little decisions that you make. Honestly, I think there's more. I think decisions get made or paths get created more accurately, more based on the small steps you take than everybody likes to talk about pivoting, but I think it's kind of what you start walking towards. So yeah, I mean, I certainly, even when I went into internal medicine, when I went into pulmonary and critical care, I didn't necessarily at that point want to go into interventional pulmonary, but I was interested in research, and it was a way that I could tie a lot of the things I was interested in together. And so I kind of made the decision to end in interventional pulmonary when I was a first-year pulmonary fellow. So yeah, I don't know if there wasn't a big moment.
Thank you. That's what I was looking for. So very interested about.
I just have a quick question kind of from that I just remembered that Dr. Kinsey, you mentioned at the beginning of the session, stating that you see a lot of lung cancer from non-smokers, like that's more common than I think you said pancreatic cancer. And I was just wondering, did you know what the cause of either of you, what the like most common cause of non-smoking lung cancer is? Because I don't know, I feel like my mind always associates lung cancer with usually smokers. So that was very interesting to learn.
Yeah, and that's right. And I mean, and rightfully so, smoking is one of the most well-established risk factors for any cancer, right? If you look at the effect size and its risk for lung cancer. And there's actually a great, just as an aside, if you ever want to read a really interesting book, there's a book called Cigarette Century, which is all about the rise of marketing and advertising, epidemiology, and how they kind of both grew up around cigarettes and the cigarette industry. So it's written by a historian. It's a really interesting book. But that's part of the reason we have such a strong association is because cigarette smoking was one of the really first well-established risk factors for a cancer. But there are a number of other risk factors for lung cancer up here. Radon is one that's very common that we see. And there's asbestos, so there's a lot of asbestos mining that went on in the Vermont area. Chromium exposure, so there's a number of other kind of industrial exposures that can result in cancer. So that's part of it, and then part of it is just genetics. And only 3% of heavy smokers will actually get lung cancer, but that's still a high number given the number of people that smoke. And marijuana use, I think, is a little under-recognized, but another inhaled organic that is, and nobody likes to hear it in Vermont, just eat it in a brownie. That's all I'm saying. Just don't inhale it. The two youngest people we've ever diagnosed with lung cancer in their 20s,
Wow.
Both were daily marijuana users. So.
Another question from the chat, how long is lung cancer usually there before it's diagnosed?
Yeah, that's a really good question. Probably more than a year, right? So we know that if we do CT scans every year to look for lung cancer. So if you do them every year, you save lives. If you do them every 2 years, that's too long and you don't catch it early enough. Right. So it develops at least over a year, probably more.
Okay. Well, we like to ask a question to kind of wrap up the session. We ask all of our participants this, just since this is centered around Vermont. But for the two of you, what is your favorite part about working with the Vermont population or just at University of Vermont Med Center in general?
I think my favorite part is that our community is small. And so commonly we see patients that are family members or coworkers or friends of either other patients that we've taken care of or people that we know from the community. And it's really nice to have them, even if it's not necessarily something that we actually take care of, but they say like, oh, you have a breathing problem. Like, oh, you should go see Sarah, because it's really nice to feel trusted like that.
Yeah, I think it's the community, both in the, the community of people that you live with, and then the community of people that you work with. I think, we work with an amazing group of people, and that's legitimate. We have an amazing team, and I think that's a big part of it. And I think that's probably my favorite part. Yeah.
Well, thank you both so much. We couldn't be more appreciative for you donating your time tonight. And the session you can find along with all of our other sessions on our YouTube channel, VT Reach, which is a great resource bank. Additionally, you can follow us on Instagram, where we also post about our upcoming sessions. And we have a cardiothoracic surgery team next month, which we're really excited about as well. So
thank you for everyone joining us tonight. And thank you again, Matt and Sarah. And we look forward to seeing you all in April for the cardiothoracic surgery team.
Yeah, thank you guys. That was great. Honored to be here.
Thank you guys.
Bye. Have a great night, everyone.
Well, you have to end it. Should have right now.